Good evening, everyone. Welcome to I believe, the third lecture organized by the Association of Cardiothoracic and Surgeons of Sri Lanka. This presentation is by my senior registrar, Dr. N. Sasiharan, and the topic is cardiac arrest in the cardiac surgical patients. This is based on the work done by Joel Dunning at Middlesbrough James Cook Hospital, now accepted by the European Society of Cardiology, European Association of Cardiovascular and Thoracic Surgery, the STS and the ATS. So without wasting much time, Sasiharan, can we start?
First of all, welcome and thank you for joining this session. My topic is on cardiac arrest in cardiac surgical patients. Right away, I'm going to the objectives of my talk. These are my objectives that I'm going to cover during my topic, upcoming slides. So first, what is the special about the cardiac surgical patients? Why we treat them different from the standard compared to the other medical and surgical patients? Why we treat cardiac surgical patients different? And how to diagnose the cardiac arrest in cardiac surgery? And cardiac surgery algorithm, how the cardiac arrest management is given in an algorithm. And the importance of defibrillation and pacing and basic life support, and about the drugs and emergency resternotomy, which is the integral part of this management that I am going to talk, and management of cardiac arrest with organized the key roles, especially the team, how they organize the team. These are my objectives of this talk. So first thing, how with the post-cardiac surgery, cardiac arrests are different. Why it's different is most of the cardiac arrests are happening in immediate post-operative hours. It's more than 80% of the cardiac arrest happening within 8 hours of post-cardiac surgery. So these all happen within ICU. So the patients are connected to the multimodal monitors and monitored by the one-to-one nursing. So it witnessed immediately. There is really no delay in diagnosis. So patients are already intubated and connected to the multimodal monitoring. So diagnosis is easy compared to the rest of the patients. And the involvement of multidisciplinary team members are available. They are already in the ICUs. Here, compared to the standard protocol, the chest compressions carry increased risk in the cardiac surgical patients who already underwent sternotomy, which may cause more harm than benefit by compression. And we will see in upcoming slides about this significance. And a significant percentage of the cardiac arrests are due to mechanical causes. Those are reversible, easily reversible if we treat, and timely intervention can serve the patient. So these are tamponade, hypovolemia, and tension pneumothorax. These are the main common mechanical causes which can be treated by reopening the chest. So this is reopening the chest is the final common pathway. So this is how the cardiac surgical patients are differ from rest of the patients. So before going to the cardiac arrest, we may be alert before get alarmed. We should be alert before the patient trickling down to the cardiac arrest. We may catch the patients by looking at the monitoring. That's why we monitor post-operatively, vigilantly monitoring for the complications, gradually drifting down of blood pressure in spite of anatropes, or sometimes may need more and more anatropes. So those patients, we had to be watchful, something going wrong, or is maybe we are losing blood, hypovolemia, or some other mechanical common causes. And progressive bradycardia. This may indicate the patient may go into arrest. And ECG changes, it may be arrhythmias, ischemic changes, or progressive bradycardia coming, the dropping down of heart rate. And patient bleeding a lot. That indicates in immediate post-op be looking the drains, but drains are false assurance. Sometimes the clotting of blood and collection of blood inside may give a false assurance the patient is not losing, but the other parameters may indicate patient's bleeding, hypovolemia. And bleeding stops suddenly. That indicates suddenly it stops. It may indicate tamponade. And patient requires the high respiratory support with CPAP or PEEP, high positive and expiratory pressure. That may indicate the third one, the pneumothorax. So these are warnings in a peri-arrest situation, we had to be alert before alarmed by the machine. So we can take some preemptive measures to stop this at some time or bridge the time before the definitive measures or the arrest, before the arrest happens. So we can check the drains frequently, especially the patients with more huge amount of drains is depend on the institutional policy and surgeon dependent. Some surgeons first hour drainage more than 200 or 400 or subsequent hours with more than 200. And this bleeding may be due to medical or surgical causes. Medical causes can be corrected by coagulation abnormalities. Then correcting with blood products, we had to highly suspicious about surgical bleeding and to be attended by, again, resternotomy. And inform the surgical team early to get the help from them and prepare for the early intervention. And bedside 2D echo, we can identify early tamponade and early collections and to intervene early. And sex X-ray, we use routinely post-operatively to check the tension. We may have unnoticed tension pneumothorax that may expand later. So we can identify that and drain by the intercostal drainage, and so may indicate some collections too. Check ECG pacings. So even though patient may be with we routinely put pacing wires, especially the ventricular pacing. Some may not work. So we had to check whether the pacing wires are working, the pacing box is working. So we had to check, this is a preemptive measure during peri-arrest. So we had to check it whether it's working. So sometimes if it's not working, we may have to go for the cutaneous pacing. Or ultimately we may have to address by resternotomy and putting a new wire. So have the defibrillator ready by the bedside. So it's here in cardiac arrest, in cardiac surgery, especially the very important different from the rest of the patients is defibrillation alarm. And if you are really equivocal in diagnosis, you can check the central pulse, but not more than 10 minutes. You should do it the central pulse is carotid or femoral. And you had to declare the cardiac arrest and start the cardiac arrest protocol.
10 seconds. You said 10.
Yeah, 10 seconds.
10 seconds. Yes. Then the first responder or first rescuer who identify the cardiac arrest should call for help. Like example, the cardiac arrest at bed 2. So other responders or other staff or member of the team will come around the step and organize method to start the resuscitation. So this is the cardiac arrest algorithm. This is in 3 steps. It's not step by step. It's in overlap and they go hand in hand in a horizontal manner. So first thing is to assess the rhythm. Second, we do the basic life support. And the final common path is the emergency resternotomy. But we don't wait till the last moment to start the resternotomy. We prepare from the beginning. Once we diagnose the cardiac arrest, preparing for the resternotomy. I will discuss in detail in the coming slides. So these are the 3 core of the protocols to initiate early effective resuscitation and early organization of the skilled personnel and early access to the equipments, especially the sternotomy pack and other facilities. Sometimes we may go over to bypass. So to make it early, it's all matter of time. So basic life support, the start after assessing the cardiac rhythm. The rhythm can be in 3 waves. It can be a fast rhythm, or rapid rhythms and slow rhythms, bradycardia and asystole. Fast rhythm can be ventricular fibrillation or tachycardia, and ineffective rhythm is pulsus electrical activity. These are the 3 ways you can produce the rhythms. So in ventricular fibrillation, tachycardia are the most common. Quarter to half of the patients in cardiac arrest are coming with ventricular fibrillation and tachycardia. So these differ from the rest of the patients and advanced cardiac life support. We treat the patient rather than giving the external cardiac compression. We give 3 sequential shocks, provided this should be delivered within 1 minute. We can't wait more than 1 minute because it is again proved by science. The success rate of the first 3 shocks are high. First shock 80%, second 60, and third one is 20. And first minute is more successful shock. The shocks are more successful, and after 2 minutes, almost is ineffective. Cardiac massage, after the defibrillation, you have to start immediately the external cardiac compression. Unless it's a pulseless electrical activity, you have to start immediately the compression. And the efficiency of the adequacy of the compression should be checked by arterial line, more than 60 millimeter mercury to maintain the vital organ, especially the cerebral perfusion pressure. And ETC or enteric carbon dioxide trace and pressures is a very good indicator. There's so many ways, and it's not my scope of this presentation. We will talk something more in later part. So this is a 6 key roles played in cardiac arrest. This is adapted from the pit crew who are preparing the automobile for the next race. So this is how they do, is a group of people act in an organized way and following the protocol. So these are the 6 key roles. I will discuss one by one. So the first one is the person who is giving the external cardiac massage. But in cardiac surgery, we are starting from defibrillator. So external cardiac compression, the person who is giving should be stand off by the bedside till the shock is delivered. And second one is the person responsible for the airway, who is take the patient off the ventilator. Is recommended to take off because we had to check the airway with this patent. Air leak is there. We had to check the air leak and manually ventilate with a back valve and mask. And we had to increase the FAO to the 100 and reduce the PEEP to 0, take off the PEEP to optimize the preload. And obviously in tension pneumothorax, we had to exclude the tension pneumothorax, and we had to do immediate needle thoracostomy. Until the sternotomy is done. Other person that highly recommended to stop all infusions to prevent the drug errors. Sometimes accidentally we may purge the anatropes, so sedation, even propofol can cause hypotension, cardiac arrest, and that we can't expect a person to be awake during the cerebral, the cardiac arrest. So unless this is indicated by senior clinicians, we can give some sedations. So other person responsible is the external defibrillation. He's responsible for internal as well as external defibrillation as well as pacing. So who is delivering the 3 sequential shocks? And if it is a biphasic, 150 or above, and monophasic, 360 or above. And especially about the drugs, in compared to the standard protocol, we don't recommend adrenaline. It's giving counterproductive, and it may cause rebound hypertension and aggravate further bleeding. So again, it's recommended by senior clinical person, senior anesthetist, can give micro aliquots in 50 micrograms up to 300 in pericardiac arrest, or before opening the chest, we can give. The amiodarone in failed 3 shocks in VT or VF. If 3 shocks are failed, we can give IV amiodarone 300 micrograms. And meanwhile, we had to continue the external cardiac compression and prepare for the resternotomy without delay. So that's, I talked about mainly about the ventricular, those fast arrhythmias. And here I'm mentioning about the bradycardia and asystole. So here, rather than the defibrillator, we had to start immediate pacing here. Patient may be already on pacing, maybe a dual chamber or single chamber. So some dual chamber box, they have the emergency button with a preset rate around 100 and maximum output. Otherwise, we had to set into that level, 100 and maximum output. It's a asynchronous mode. And especially in the pulseless electrical activity, we have to pause the pacing. Sometimes the background, the VF is hidden in disuse. So we have to stop, pause the pacing to assess whether VF is going in background. If that there, VF had to be managed in the mentioned way. Otherwise, pulseless electrical activity should be managed with the compression. And in the absence of pacing wire, it's not recommended in the protocol, but still you can try atropine 3 milligram IV. So during these measures, you may not be able to produce the adequate pressure. That indicates that these mechanical causes are there, and it warrants you have to open the chest or prepare immediately for resternotomy. These are the common tamponade, hypovolemia, and tension pneumothorax. So let's talk about the conduct, how you conduct the emergency resternotomy. So like I mentioned, there are 6 key rows of plate and another 2 operators preparing from the beginning. And I didn't mention 2, the rest of the 2. One is the leader and one is the coordinator. Leading played by the senior personnel, maybe anesthetist or surgeon, who is coordinating and making sure the team is adhering to the protocol and making sure the adequacy of the compression and resuscitation. The coordinator is the senior, the in charge or nursing staff, who is acting on the periphery of the bed and making sure the supplies and calling somebody. We can waste time in calling or arranging somebody. So she will make sure, and she's periodically update the leader, what's going on and what's the trend. And she will make sure the documentation for legal purpose too. So as the rest of the 2, the operators will be preparing for sternotomy. No need to waste time in hand washing, but make sure it's done aseptically. They should practice donor gown aseptically with the long sleeves and non-touch touch technique of gloving. So they prepare. It should be done within 4 minutes because all should be done in 5 minutes. Already we have take 1 minute for defibrillation, and rest of the 4 minutes, within 4 minutes, we had to open the chest. So ask the team to continue. The person is continuing the CPR. Then when operators, these sterile operators are ready, they have to inform, stop the CPR and quickly remove the dressing. And after that, they will apply a drape. Actually, it's a commercially prepared all-in-one drape with a central window with the IO band. That is not available here. Our sir has made some modification with a single cloth, and we can cover the whole table with a central window to modify it by pouring half a bottle of betadine over the chest and cover the rest of the table. You can restart the CPR. It's called swapping from non-sterile CPR to the sterile CPR. You had to again restart the CPR until you're ready to open the chest, because we have to get delivered the sucker, internal defibrillator, and 5-piece tree. I will talk about the 5-piece tree coming slide. So immediately when you're ready, then you have to stop CPR and cut the same incision, the previous incision, down to the wires. And one is cutting the wires, another one pull out. So we have to communicate to reduce the time consumption, and we give a commentary to make sure that the rest of the team aware what's going on. And put the retractor and open the sternum and give some release. And if it's a tamponade, it's open the chest and give a relief. Now, this is a 5-piece tray I mentioned. This is to reduce the confusion, because the standard sternotomy pack has more than 30 pieces. So you can't waste time in picking up these instruments and that particular time within 4 minutes. So this is a single piece retractor, wire cutter, twister, and a scalpel with handle, and the sucker. Here the sucker is not mentioned, but sucker tube. These are the only 5. If you need more, you can get it later. These are the 5, and we modified some more because internal defibrillator also we need. We can get it from the ICUs, because fortunately we have the ICUs very close by to the theater. So we can get the defibrillator from the theater. Internal defibrillator should be compatible with the machine in the ICU. So principle of resternotomy, why we do is internal cardiac compressions are more, the efficacy is high. They produce cardiac output more than twice, and cerebral perfusion pressures more than 4 times than the external cardiac compression. And the compression, external cardiac compression, more traumatic, because already open chest sternotomy with the wires can injure the ventricle or heart. So internal massage is more effective, and there are so many options available to us, and access to the heart is easy. First thing is we scoop out the clot and suck out the blood, excess blood, and we can assess the heart contractility, the adequacy of the contraction, and the rhythm, where there's a rate of the rhythm, where there's ventricular fibrillation or tachycardia, where again we can deliver the internal defibrillation, internal cardioversion. And immediately, in other cases, electrical activity of bradycardia and asystole, we can start immediately the internal cardiac massage. And if there's a bleeding, we can control with a finger. So I will show the internal cardiac massage. how the technique, there are so many ways, especially the one hand and two hand techniques. Two hand techniques recommended for especially who are not experienced, is safe. So first you have to open the retractor widely to make more space, and right hand into the pericardium or the apex where the grafts are not much. We are not putting most towards the apex, so it's safe to put the hand there and do some rubbing against the pericardium. And left hand over the right ventricle, and you put gentle clapping motion. With then you can produce the effective arterial blood pressure, again 60 millimeter mercury, and you can see the ETCO2 waveforms. It should be more than 20 millimeter mercury ETCO2. It's a team leader will be informing you whether it's adequate or we have to produce more. And internal defibrillator paddles should be delivered to the field in case if you need, and shocks given biphasics 20 or more than 25. And in asystole, we have to consider putting a new pacing wire, but it's not working. The previous one is not working. Beware, during the internal cardiac massage, you can cause more harm than benefit. So you should be aware that there are grafts in CABG patients in memory, internal memory on the left side, crossing from left to the central, and other grafts. You may avulse the grafts from top and bottom ends. And before of the lifting the heart, especially mitral valve repair and replacements, you may fracture the heart in the AV groove, and in valve sutures may cause dehiscence and disrupted. And friable right ventricle, you may stick your finger into the ventricle and can cause perforation, especially the one-hand technique with the thumb into the right ventricle. So meanwhile, you should not forget these 4H or 5H and 5Ts. So already we have addressed these tension, pneumothorax, hypovolemia, and tamponade, and other hypoxia, hypokalemia, electrolyte imbalances. With even immediate post-rapid throughout, we measure serial blood gases and electrolyte measurements. So we used to address that. If not, we had to address these. Otherwise, the arrest will be recurring or not going to respond. So when you are succeeded in resuscitation, you're going to get the return of spontaneous circulation. So we can, again, we can see the evidence visible on the heart. You can see contractions, starting contractions, and ETCO2 waveforms returns and arterial waveform returns. By these measures, you can see the return of spontaneous circulation. Again, you have to reassess whether there's ongoing bleeding, and if you had severe excess bleeding, and plan for reasonable period observation. You can't straight away decide to close the chest, and you had to decide whether to leave it open or close it. If you are done in the ICU, you had to bring to the theater, and you had to do the definitive treatment to control the bleeding, put more sutures, and if you feel you had to irrigate the mediastinum, you may have to irrigate it. So you had to decide after some period, reasonable period of observation, and leave the chest open in uncertain patients, precarious. They may have very risky patients or uncertain for bleeding or contractions or high CVP or high anatropic supports. You may have to decide, leave it open. In post-cardiac arrest care, especially after the spontaneous circulation returns, you had to prevent from happening again. The cardiac arrest, if you don't treat the underlying cause, may recur. And limit the damage, and you had to protect the vital organs, especially the nerves tissues, to prevent the adverse neurological outcomes. So you had to limit the damage, and I will tell the bundle of care after the return of circulation. So again, airway, breathing, and circulation. You had to look after the airway. If it's not definite airways there, you had to go for definite airway and optimize the ventilation. Here, FaO2 should be bring back to the needed level, not to the 100, because it's again like ischemic reperfusion injury, and more oxygen causing more free radical formation, and it causes the vicious cycle. It's counterproductive. So we have to reduce the FaO2, which necessary to maintain the PO2 around 98 or 100 and saturation around 100. So you can depend on the blood gases. You can assess serial blood gases and check it, and according to that you can bring down the FaO2. And you have to treat the hypotension with sometimes you may replace the volume, blood products, or judicious use of anodrops. That also should be limited. Than giving much anodrops can produce again more aggravate the bleeding. And correct the milieu with the blood gases, electrolytes, and underlying the causes should be corrected. And targeted temperature management is another way of preventing the vital organs, especially the nerve tissues, but it's not recommended in this protocol, but still worth to consider here in prolonged resuscitations, especially prolonged resuscitation. You can consider that. And again, I mentioned the correcting and preventing the causes like electrolytes. So another way, one, you succeeded, may or may not succeeded. So you have to decide at some point to discontinue. Traditionally, we continue the resuscitation up to 20 minutes. But it's depend on multiple factors, age, cardiac status of the patient, maybe, and the cause of the disease. It depends on the disease and the factors which cause the cardiac arrest, whether you have corrected it or not. So you may have to resuscitate longer in young patients with a good myocardial function and the underlying causes are corrected. And you see some good evidences in resuscitation. ETCO2 more than 20 and arterial 60 is a good indicator. ETCO2 is very good indicator. If it is persistently less than 10 millimeter mercury, it's a good sensitive indicator that your resuscitation is not going to work if it is less than 10 millimeter mercury. So you have to decide according to this whether to continue or not. And these are the common scenarios with sternotomy patients, but some special situations is, although it's uncommon, we have to be aware and we should be able to manage these patients too. So one thing is patient with open chest. Sometimes we, as I mentioned earlier, we decided to keep the chest open because of this uncertainty in patients with sometimes bleeding, high inotrope supports, and when you're closing the rising of CVP and pressures. So we decided to keep it open. But in this patient, where the managing is a bit of easy because their chest opening is easier. There is no wire to cut. Till that moment, you had to compression should be given in the middle of the chest, and the packs we put may give some support. Otherwise, we may harm the chest heart. So other situation is where the minimally invasive cardiac surgery now is increasing in the numbers and advancing technologies. And these are not through the sternotomy, various alternative approaches, thoracotomy, mainly the right thoracotomy for mitral surgeries, left thoracotomy for coronary bypass mid-caps, hemisternotomy for aortic surgery. So various incisions are there. So here, the standard protocol is difficult to perform, and the operating surgeon should make sure his team is aware how to manage the emergency situation when a reopening should be performed. And internal massage is difficult to perform, especially through the right thoracotomy, and is highly recommended not to extend the thoracotomy and to do the sternotomy, because it's a very, the access to the heart is easy, and most of the staff are familiar with the sternotomy. So, and it should be performed by a good operator, the performed surgeon, because it's not already open. You are opening again. So the sternoshoe should be available. Until that moment, you have to keep on compressing. The external cardiac massage should be going. Other category people are the pediatric patients. Again, it's similar to the adult patients. We can follow the same protocol here. And it should be with the other pediatric life support guidelines also should be merged, or we should read that to complete these guidelines. But otherwise, it is similar to the adult. The protocol is similar. And the dosage of the medicine should be corrected to the body weight and surface area. And especially in the intra-aortic balloon pump patients, diagnosis may be sometimes tricky because it may producing waveforms. But again, other waveforms are all go flat. And especially in the intra balloon pump, the cardiac component of the waveform will be lost. So again, it's easy to diagnose. But in come to this arrest, we have to activate to the pressure trigger. We usually put in the ECG, trigger by ECG. But in new versions of machine, they automatically change from ECG trigger to the pressure trigger. Otherwise, you have to make sure it's going to the pressure trigger, 1-to-1 and maximum augmentation. If you think you have to stop resuscitation for some time, you have to change to internal trigger with the same rate. So the final decision sometimes occasionally can happen it should be decided by the surgeon or anesthetist going on bypass. Some advanced centers, they decide even preoperatively to go on bypass if the patients go on cardiac arrest, depend on the underlying pathology. Some causes are with good reversible cardiac arrest. It should be a good, the status of the heart should be there. And it's again timely. It should be within 30 minutes to go to the pump. It's called eCPR, extracorporeal membrane oxygenation CPR again. So we need to take the patient to theater in our setup. So it may interfere with the resuscitation and it may take more time. And we may have to go central cannulation and we can't wait for the ACT. Give 30,000 units of heparin IV and 10,000 to the pump. Then we are going to the bypass. It's decided by the surgeon and anesthetist. So finally, in the ward, it's not common, but can happen. In the ward, maybe patient may send to the ward early when he was stable in that time, or patient who are waiting for surgery in the ward preoperatively, they may go into arrest. So here is different is we may not witness, may or may not witness immediately. So within the timely intervention may not be possible, and facilities and opening the chest and with the equipments and the staff is a very challenging in the ward and associated with the poor survival. Starting the standard protocol is advised or call for the cardiac arrest team. Earlier, it advised to take the patient immediately, scoop and run to the ICU, especially when the ICU, theater, and wards are very close by. In our setup, I think it's very challenging. And it's even in developed countries, they have the average time taken from the ward to the ICU is 9.5 minutes. It's almost the golden time is passed. So, but occasionally the patient survives. So we had to still try the cardiac arrest, but the senior member still can decide to go for resternotomy if time permits. The important thing is more than 10 days, within 10 days, the opening chest is recommended. But after the passing 10 days, it's difficult because of the additions. But still, the surgeon can decide whether in the margins, whether it's a 9-day, 11-day, or 12 days, he can decide, still depend on the balance between benefit and risk of opening the chest. So finally, the training, the education as well as training should be given because it's all depend on the team members' education. Without their understanding and input, we can't make it happen. So we have to educate them. It's depend on the regular sessions, training sessions. Important that all members are well trained. Reopening is not only done by the operator or surgical team, should be done by anyone, including nursing officers. In especially developed countries, they are trained nurses can open the chest. Nurse-led ICUs are there, so they do open. And developed countries conduct regular training sessions, so they keep on updating and keep in touch to reduce the time for the resternotomy within 5 minutes. Refresh their knowledge by reading, watching relevant videos. There are plenty of videos available on YouTube, very updated videos, you can see it. And anesthesia, ICU, and nursing officers, medical officers who never seen. So many of them have seen, but somebody may not have seen how the reopening is done. So they should at least visit when reopening is being done in the theater and learn non-touch technique of gloving. So we can't waste time washing hands, and they should be able to don the gown and put the gloves aseptically. So wrap up my presentation with the take-home message. The different nature of cardiac arrest after cardiac surgery. You should understand this is different. The cardiac surgical patients are different from rest of the patients. So that's why we bring the modification to the protocol, and is accepted by the European Resuscitation Council as well as the American Heart Association. Algorithm for the cardiac arrest after cardiac surgery. This is the whole essence of this presentation or talk, that algorithm. That says everything. The external cardiac massage can be deferred until the initial defibrillation in the tracheotomies or pacing in the Brady or asystole, provided it should be done within 1 minute. So you can't wait more than 1 minute to start fibrillation or pacing. And cardiac compression must continue till the emergency resternotomy preparations are ready. Till you are ready, you have to continue that. And resternotomy is an integral part. This is a final common pathway for this multi-step process. So these are my references, especially the British Journal of Anesthesia is the best of these, highly recommended. Okay, that's all.